Hello, everyone, and thanks for joining today's webinar, Vaccinating Every Child, Promising Strategies for Reaching Zero-Dose Children in Bangladesh and Nigeria. Please continue to introduce yourselves in the chat with your name, country, and role so that we can all get to know each other today. My name is Erin Brookhazen, and I'm the project director for the Gavi Zero-Dose Learning Hub from JSI. And it's a pleasure to have you join us today for this important webinar in our ZDLH 2024 webinar series. The Zero Dose Learning Hub addresses immunization equity through the generation of evidence and learning around effective methods and approaches for identifying and reaching zero dose in under-immunized children. The Zero Dose Learning Hub supports 4 country learning hubs as they advance the uptake of research and evidence to improve immunization policy and programming, especially at the subnational level. Next slide, please. Before we get started today, let's take care of a few housekeeping items. For those who would like to continue the webinar in French, click the interpretation icon to set your channel to French. Those who wish to stay with us in English, you will also need to click on the interpretation icon to set your channel to English, as we will have interpretation from French to English, and you'll need to have selected those audio channels to hear that. Pour écouter le webinaire en français, cliquez sur l'icône d'interprétation pour sélectionner et le canal audio français. Ceux qui souhaitent écouter le webinaire en anglais devront sélectionner et le canal audio anglais. Next slide, please. Please submit your questions for the panelists in the Q&A box. Panelists will either reply back to you via text in the Q&A box or will answer your question during the discussion portion of this webinar. Next slide, please. If at any point during the webinar you are unable to hear, please make sure you've connected your audio by selecting the headphones icon at the bottom of your Zoom window labeled Join Audio. If you still cannot hear the presenters or see the presentations, try leaving the meeting and rejoining again with a link provided. Please send a message to everyone to ask for support during today's webinar. We have a support team monitoring the chat and able to provide further assistance. Closed captioning in English has been enabled for this meeting. To view the live English subtitles on your screen, click the closed captioning icon and select Show Subtitle. Next slide, please. Now it is my pleasure to introduce the facilitator for today's session, Gustavo Correa, a Senior Program Officer at the Measurement, Evaluation, and Learning Department at Gavi. Gus leads the Zero Dose Learning Agenda for the Gavi Secretariat. Thanks again for joining today, and I'm happy to hand it over to Gus to introduce today's speakers. Gus, the floor is yours. Thanks so much.
Thank you very much, Erin, and welcome everyone for our webinar today. This webinar is related to our flagship learning perspective project in Gavi, Zero Dose Learning Agenda, the Zero Dose Learning Hub. We have the 4 countries, Bangladesh, Nigeria, Uganda, and Mali, with a global learning partner, which is JSI Consortium, that help us in that project. As Erin already said, the objective is to generate evidence on zero dose programming at the country level. Those are projects that are embedded in country programs and align with the country's zero dose learning agendas. We hope that they can shed light on what works and what not work, and the key enablers and drivers and barriers for countries and the alliance. This webinar will focus on the REACH component of the IRMA framework and the approach that are being used at the country level in those 4 countries. This is part of a series of 2 webinars highlighting and discussing the diversity and variation of this REACH approach for different types of contexts and different typologies of zero-dose communities. Because those children tend to cluster in pockets of communities under multiple deprivations, the zero dose learning hub approach is also very targeted to be able to generate evidence on those pockets. The objective is not to generate learnings that are representative for the whole country, but rather make really deep dives on specific communities. Um, that highlights the need for a good theory behind those programs. Um, and that's going to be discussed by the Learning Hub countries today as well. These theories of change, they are very useful to better understand the context, the barriers of these specific contexts, and what needs to be done to change those barriers. That provides a good basis for understanding how the programs are progressing, to inform an enhanced monitoring approach that is also going to be part of the research of the learning hubs, and also to understand how good a fit the interventions may be to promote change in those different contexts. I would also like to highlight that a good theory is also very relevant to inform the generalizability of the findings, acknowledging the complexity of those different settings. If a theory works well to promote change in those specific settings, there is also a good chance that they will also work in other similar settings facing similar barriers. Quantitative and qualitative data will enhance the understanding on how the programs are working. So after this kind of a brief explanation, I would like to introduce today's speakers. First, Hamel Das is a senior statistical officer of ICDDRB in Bangladesh. He completed his Bachelor of Science and Master of Science degrees in statistics from University of Dhaka, Bangladesh. And his research interests include statistical methods applied on outcomes related to the health system, especially in child immunization. Dr. Helshinli Waziri is a field epidemiologist working with AFINET in Nigeria as the technical lead for capacity building and research on the Zero Dose Learning Hub. He has more than 10 years working experience in public health space. He has also worked as a clinical microbiologist in the Jos University Teaching Hospital in Nigeria. Finally, we have the honor to have our discussant today, Dr. Shizoba Wanadi, who is an associate scientist at Johns Hopkins Bloomberg School of Public Health, with nearly 3 decades of experience as a public health physician and implementation science research. She's a recognized leader in the immunization field. Dr. Wanodi currently serves as the Director of Immunization for USAID-funded Momentum Country and Global Partnership Project. And Dr. Wanodi has helped to shape the global immunization policies in her previous roles on the Immunization Agenda 2030 Coordination Group and the Gavi CSO Constituency Steering Committee. She is also the founder and convener of the vaccine coalition called Women Advocates for Vaccine Access. And without further ado, I hand off to Dr. Hemeldas for the first part of the presentation. Thank you.
Thank you guys for giving me the floor. Greetings to everyone. I'm Himel Dash, and the topic of my presentation is implementation research for reducing zero dose and under-immunized children in Bangladesh. The principal investigator of this study is Dr. Mohammad Joshimuddin. Next slide, please. Bangladesh Country Learning Hub conducted a rapid assessment where zero dose and under-immunized children as well as mixed communities were identified over the country in sub-district level through both secondary and primary data collection and analysis. The results obtained from the rapid assessment ensured that there exists zero dose and under-immunized children in different geographical areas of the country, especially in Haur, that is wetlands, Chor, that is sandy or silty lands, coastal, hilly, plain, and urban slum areas. In rapid assessment, both qualitative and quantitative analysis were conducted to explore the reasons behind zero dose and under-immunized children. You can see here area-specific demand and supply-side factors obtained from the assessment. Some of these factors are common for all areas, whereas some are area-specific. The identified demand-side factors are migration, misperception, river erosion, and etc. Where we can see some supply-side factor such as lack of interpersonal communication, difficult route communication, lack of human resource, denominator issue, etc. I need to say about the denominator issue that DHS2 data use projected value rather than using the real data from the birth registration system for calculating denominator, that is actually the number of target children. This ultimately creates a long-term strategic problem. Next slide, please. Gavi and the Global Immunization Agenda 2030 have a strong determination of establishing equity in immunization. This can be done reducing the zero dose and under-immunized children and reaching the missed community. Hence, the findings from the rapid assessment suggested to conduct implementation research so that appropriate approaches for reaching zero dose and under-immunized children as well as missed communities can be developed to achieve the target of Gavi mission. Next slide, please. Hence, we plan an implementation study so that we can suggest some appropriate method to bring the zero dose and under-immunized children into the health systems. Next slide. This implementation study follows quasi-experimental pre-post design. The study sites are selected in geographical locations which are identified in our rapid assessment after confirmation through the lot quality assurance sampling procedure. We have selected two sub-districts from each of the geolocation that were identified as missed communities from our rapid assessment. An intervention and a corresponding comparison area from each selected districts were included in the study. This table shows the selected areas for the study. Next slide, please. Here, the steps we have followed for designing the intervention is given. At first, we identified the evidence-based intervention that have been already implemented in hard-to-reach areas and hard-to-reach population. Then we shared our findings with key immunization stakeholders and discussed with them. After receiving the suggestion and recommendation through in-person meetings and the seminar of rapid assessment finding sharing, we have revised the intervention accordingly. Afterwards, we used human-centered design approach to understand the drivers of non-vaccination within families and the interventions likely to be successful in improving uptake of the routine immunization. Finally, we have developed interventions according to appropriateness of different geolocation for the study. Next slide, please. These and the next slide mainly shed light on the intervention designed for our implementation research. We have designed some interventions which are being implemented in all of our study areas. These are training of government service provider, EPI e-checker system, use of e-screening checklist, distribution of BCC materials, modified EPI schedule. However, e-screening checklist is being implemented only at the rural sites, not the urban areas. And modified EPA schedule is being implemented on the basis of need, such as evening sessions and weekend sessions are being held at urban areas, and crash programs are being organized at hard to reach coastal and chor, that is city land areas. Beside all of these interventions, there are some individual interventions that are being implemented at a specific particular area according to the need, such as in chor areas, that is silty lands, advocacy meetings are being conducted for community engagement. Next slide, please. In hilly areas, that is wetlands, interventions are being implemented to strengthen the EPA support group. In our areas, that is wetland. And hilly areas, alongside the advocacy meeting, existing NGO worker known as Parakormi are being involved to identify the zero-dose children. In coastal areas, community healthcare providers are providing health education to the caregivers to increase the knowledge about the immunization. Moreover, we have introduced e-supervision checklist at coastal areas. EPA supervisors are using this online-based checklist tab. They use it when they visit to any EPA sessions or outreach center. This will help to strengthen the monitoring and the supervision activities. In plain lands, court-led meetings are conducted to engage the community, and in urban areas, besides the community engagement, NGO work counselors are providing health education to increase the knowledge about the child immunization. Next slide, please. Now you can see the theory of change of our implementation research. we identified some barriers while we were designing the intervention step by steps. The barriers are, I can mention that, lack of information, lack of interpersonal communication, traditional and lengthy reporting system, misconception, and so on. To reduce these barriers, we identified that there is need of some inputs which are adequate resource generated, appropriate measures taken to identify zero dose children, adapt intervention based on the geographical variation, effective involvement of partners. These inputs can be provided by following some structured process, which are our proposed intervention. These interventions are already mentioned in my previous slides. We hope that after the successful implementation of our intervention, we will be able to identify the number of zero dose children, increase knowledge about immunization, especially zero dose and under immunized children, increase the availability of immunization service, document barriers to intervention, and mitigate the risks. I want to mention that the implementation status information will be accessed timely so that we can adjust the inputs on time and appropriately according to the updated information. Thus, we have the opportunities to update or adapt this theory of change during the IR process based on our findings. Overall, a successful implementation of intervention will result to reduce the number of zero dose as well as the under-immunized children. However, throughout this process, we have identified some challenges till date, which are natural calamities, shortage of human resource, and so on. We are sharing our challenges and support needed to the national and sub-national committee on a regular basis to ensure smooth running of our implementations. Next slide, please. Now, I will share evaluation design of this study. Both impact and process evaluation will be performed to measure the change due to the implementation of the interventions. In impact evaluation, as this is a 4-cell study design, we will conduct a survey in both intervention and comparison study area before and after the implementation of the intervention. We are glad that baseline survey has been completed in our 6 intervention and 6 comparison area before starting the implementation of our interventions. After completing the intervention implementation part, we will conduct an inline survey in all of these 12 areas. The comparison between baseline and baseline data will provide the measure of intervention impact. However, we also conduct qualitative approach in process evaluation, such as observation of field activities, key informant interviews with service providers, and focus group discussion with our frontline healthcare provider. Next slide, please. Currently, we are implementing intervention in higher areas within the existing health system of Ministry of Health and Family Welfare, starting from December 2023, with a plan to complete the implementation within a year. The key learnings till date can be summarized as EPA stakeholders engagement and human-centered design approach is highly needed in designing the intervention. Moreover, to keep track how the intervention going, a committee with EPA stakeholders at sub-national level is necessary. We will update the country learning hub. We will share our learnings as soon as we learn about our new learnings. Next slide. And we are at the end of my presentation. Thank you all for your kind attention. I would like to hand over to Dr. Helshilni Waziri for delivering his presentation.
Thank you very much, Hemel. Hello, everyone. Good morning, good afternoon, good evening, depending on what part of the world you're joining from. I'll be speaking on the rich learning strategies of the Zero Dose Learning Hub in Nigeria. Next slide, please. I would be speaking based on this outline too. Next slide, please. Immunization remains the most cost-effective method of prevention against diseases worldwide. Immunization currently prevents more than 4 million deaths and is estimated to prevent an additional 1.5 million if vaccination coverage improves. Africa accounts for over 30 million children under 5 years suffering from vaccine-preventable diseases annually. And Nigeria accounts for over 2.2 million zero-dose children with 70% Penta 1 coverage and 57 Penta 3 coverage, according to most recent multi-indicator cluster survey. The country has developed innovative strategies in line with the Immunization Agenda 2030 and Gavi 5.0 to reduce the number of zero-dose children by 15% by 2024 through the National Primary Healthcare Development Agency across 100 prioritized districts or local government areas, as we call them. There are currently two strategies, the Zero Dose Reduction Operational Plan, otherwise known as the ZDROP, and the Identify, Enumerate, and Vaccinate, otherwise known as the IEV. Next slide, please. So we conducted a rapid assessment to understand the behavioral and social drivers of vaccination, focused on thinking and feeling, motivation, social processes, and practical issues on the barriers and facilitators to routine immunization. We found that about 91% of parents or caregivers feel vaccines are moderately safe for their child, and 90% of caregivers feel vaccines are moderately or very important for their child's health. And about 88% not needing permission from their spouses before taking their children for vaccination. Next slide, please. The Zero Dose Reduction Operational Plan was designed in 2023 with the aim of enhancing immunization efforts to reduce zero-dose cases through optimization of existing strategies. It employs a bottom-up approach, which is structured and data-driven, and was developed as a quick strategy towards revamping routine immunization activities through integration of routine immunization with other primary healthcare services, strengthening existing routine immunization processes, and reducing the number of zero-dose children in each district or LGA. The bottom-up approach spanned across the different thematic areas in routine immunization, including service delivery, data management, leadership and communication, advocacy, communication, and mobilization. Next slide, please. This looks at the activities for the ZDROP plan in detail for the various thematic areas. For example, the weekly integrated subnational routine immunization meetings, supportive supervisions at health facilities by partners, integrated outreach services to prioritize settlements, to mention a few under leadership and governance, daily fixed sessions in tertiary, secondary, and urban primary healthcare centers, and identified private health facilities, extended routine immunization sessions for the prioritized LGAs on market days, provision of integrated services for RI and COVID-19 for both mother and child, intensified line listing, reconciliation, defaulter tracking, referral activities, and demand generation through community engagement, community participation, and community ownership. Next slide, please. So the IEV strategy leverages geographical information system technology and census approach aimed at complete enumeration of children 0 to 59 months of age across these prioritized LGAs. This strategy aims to reduce the burden of zero-dose and under-immunized children across the highest burden LGAs. The goal is to reduce the number of zero-dose and under-immunized children through enumeration, vaccination, and linkage of eligible children to routine immunization and other primary health care services. Every child identified here will be enumerated and given a coupon card and linked to a primary health care center where they can access integrated primary health care services to improve equity, strengthen surveillance of vaccine-preventable diseases. Next slide, please. The AFINET AHBN consortium aims to conduct a longitudinal study to measure change over a one-year period. The implementation research focuses on two frameworks: the REACH, Effectiveness, Adoption, Implementation, and Maintenance Framework, otherwise known as the RE-AIM, and then the Practical, Robust Implementation and Sustainability Model Framework, otherwise known as PRISM Framework. We hope to identify and analyze factors affecting current strategies for reaching zero-dose children and missed communities in terms of barriers and facilitators to immunization. We also hope to evaluate challenges and support for the zero-dose reduction operational plan and IEV strategies in various settings like rural areas, hard-to-reach areas, border communities, special populations, and urban slums. We also hope to assess effectively the ZDROP and then IEV to identify and reach zero-dose children and missed communities in different settings. Next slide, please. So the first objective of the implementation research is to identify potential barriers and facilitators inherent in the Z-drop plan and IEV enriching zero-dose children. The second will be to assess the effectiveness and efficiency of Z-drop and IEV enriching the children in different implementation segments. And the third will be to examine the cost and the cost effectiveness of the Z-drop and IEV to reach zero-dose children when compared to each other, and then to no intervention. And then we will provide evidence-based recommendations on incremental costs for reaching these children. Next slide, please. The anticipated risk will be competing government priorities, increasing insecurity, suboptimal integrity of existing data, and limited data information sharing amongst partners. We hope to leverage the national policies and strategies, trained healthcare workers and security personnel, accountability framework, and the emergency coordination centers we have. Also the existing Gavi investments and Affinet's memorandum of understanding with National Primary Healthcare Development Agency and academia. Next slide. We will employ a mixed methods approach using a control and intervention local government areas or districts. 2 states have been selected, Bauchi and Sokoto in this case, and then 2 local government areas also selected in each state with focus on urban, rural, and riverine, nomadic and unsecured or far-to-reach areas. 1 intervention and 1 non-intervention LGA with similar characteristics will be selected. Based on guidance from previous studies, 10% of health facilities in each of these states will be selected, 21 for Bauchi, and then 11 for Sokoto. Our study population will be RI Technical Working Group at the national level, the routine immunization program managers at the sub-national level, then health workers in charges and ad hoc staff at the facility level. Caregivers also of children between 0 to 11 months and 11 to 33 months would also be sampled. Next slide, please. Instruments for data collection have been developed and ready for field testing. Ethical approval for implementation in the 2 states have been secured, and baseline is scheduled to commence in July 2024. Next slide. As part of the limitations we envisage, the zero-drop operational plan and IEV, besides the pilots, are yet to commence implementation, even though it presents an opportunity to conduct a baseline, but changes may occur as implementation occurs, and this may, however, affect some of the outcomes. Instabilities in study areas that affect the list of settlements. Some settlements have, however, been merged and new ones created. Next slide. So in conclusion, the Nigerian government and partners have put in efforts in improving routine immunization coverage by addressing the challenge of zero-dose children and mixed communities. Nigeria, however, still accounts for a huge number of zero-dose children due to many factors, including, but not limited to poor healthcare, infrastructure, insecurity, social and behavioral factors, and also hitherto, there has been no structured framework informed by robust evidence-based data to support decisions and planning on routine immunization interventions. The Zero-Dose Learning Hub, as part of the Gavi IMA framework and immunization agenda, has designed and implemented, even though some are still ongoing, several activities aimed at providing government with structured evidence. With this, thank you for listening. This is the end of my presentation. Thank you.
Thank you very much to Dr. Waziri and Dr. Haz. It's my pleasure to serve as a discussant on this. I think it's really great that this effort is focused on zero-dose children because they have been overlooked for decades. And one of the reasons is that we grouped them under vaccinated children and did not recognize the distinct problem that zero-dose children are. And it wasn't until the seminal publication by the Equity Reference Group that this perception changed when they highlighted the magnitude of the zero dose issue and pinpointed where zero dose populations concentrate. This brought much needed visibility to the problem. And in addition to that, the Gavi establishing the Equity Accelerator Fund provided essential resources and that attracted a lot of stakeholders, both EPI and non-EPI stakeholders into the space. And then additionally, the articulation of the IRMA framework has given academics like us and partners in the field and EPI programs a solid foundation for designing action against zero dose. So it is clear that zero dose is now a household name. There are a lot of unknowns about zero dose, but there is a lot there is quite a bit that we know currently about zero dose. This webinar is focused on how to reach zero dose children. And the IRMA framework articulates that before you reach them, you have to identify them. And many countries have started to answer that question of where are the zero dose children? Like Dr. Waziri mentioned, in Nigeria, there are 100 local government areas that have been identified as priority LGAs. So for the most part, we know where the zero dose children are. And then for the most part, we know some of the correlates of zero dose children, right? Like zero dose children are more likely to have mothers who have not attended school. But there's still a lot of things we don't know about why children are zero dose in specific contexts. And that is where these studies really shine forth. Even in this context of the unknowns, there are some things that in the community, the immunization community, we have consensus that has started to crystallize. First of all, we have consensus that the problem of zero dose is context specific. So what the problem in Sokoto is may not be the problem in Owerri. So we need to look at specific, we need to look at the issues in specific areas. The second thing we've agreed on is that for us to understand the reasons for zero dose and to develop effective strategies, we need to center it on the humans. We need to center it on the humans that are seeking vaccination for their children, that is the parents. We need to center it on the humans that are responsible for providing the services, that is the health workers. So I've seen a lot of that reflected in the two presentations that have been made here today. So that is definitely in line with what the consensus is in the field around how we identify what should work for zero dose. But we know how to, or we've agreed on how to go about identifying the problems. But what we don't know yet is whether these problems will actually work. So that's still an unknown. And that is why the Zero Dose Learning Hub is such an important partnership, research partnership, that is helping, along with other research efforts, to fill those gaps on whether or not these tailored interventions will actually work. And if they work, what is the mechanism behind their effectiveness? So I wish to commend the Zero Dose Learning Hub for sharing their research journey along the way with stakeholders in the community, inviting us to chime in on their questions, on their approaches, on the interim findings, and the future directions. This is really commendable because some of the insights you're gaining, even along your research journey, will be useful to the programs. And we know that the programs cannot wait because vaccinating disadvantaged children cannot wait. So today we've heard two excellent presentations from Bangladesh and from Nigeria on the work that they are doing. Dr. Das presented their plan to conduct a mixed method quasi-experimental study. And what struck me about their study is that they are testing approaches for reaching zero dose and under-immunized children, as well as mixed communities, and then bringing them into the health system. So I interpret that as getting them to go to health facilities and access care. So that's a point I'll come to later. Dr. Waziri has presented a proposed evaluation study of a national program that is designed as, and it's been designed as a mixed method quasi-experimental before and after study. And in their study, they will identify the potential barriers and facilitators associated with the program, the effectiveness and efficiency, costs and cost effectiveness of the Z-Drop program and the EV interventions being implemented by the national EPI programs. So what you would notice is that there are some similarities between the two studies. One is, in terms of the similarities, they are both quasi-experimental pre-post intervention design. This is a strong design, and given the complexity of the study, this is pretty much the best design you can get. So that's kudos to them. In addition, the design has been informed by formative studies, rapid studies. So they were not designed in people's offices, but really based on data that's been gathered. It's also been human-centered, and then also stakeholders that have been involved. So that is a good entry point for a study. One major difference I can say between the two studies is that the Bangladesh study is designed and implemented in the context of a project. So they are responsible for implementing the program, while the Nigerian study is nested within an existing intervention that has been designed and is being implemented by the national and EPI program. So both of them have their pros and cons. The Bangladesh study has more control of the timing and execution of the intervention, and so just because of the way it's been designed. However, one of the things they may consider is how well the project findings and insights, or what it would take to get the project findings and insights to be taken up and scaled up in the country, because the essence of this learning hub is for insights to be taken up and scaled up. The Nigerian study, on the other hand, has aligned its evaluation onto a strategy that's already been implemented or planning to be implemented at scale by the EPI program. So the insights from their evaluation should already have fertile ground to land on and take root. But a challenge, which Dr. Waziri has mentioned, is that they are uncertain of the timing of the implementation of the Z-Drop and the EV intervention. So this is something that is not within their control. But both studies give us a good example of how you can generate learnings, either by setting up your own study or by embedding it within an existing program. So some of the things I found interesting about the two studies, I was just checking the time, is number one, for the Bangladesh study, it struck me that in all the 6 geographical settings where you mentioned under the background, that the barrier that were mentioned as major barriers, were mostly related to access. I mean, when it comes to the demand side barriers, were mostly related to access. For example, 5 of the 6 settings mentioned that migration was an issue. Perhaps as families move to new areas, the nearest health facility becomes too far for them. 3 of them mentioned that river erosion was a problem. Perhaps the roads have been washed out or travel is more difficult. But we noticed that misconception was identified in only 1 of the 6 locations. So it seems like the zero-dose reasons revolve more around difficulties parents have in taking their children to get vaccinated. So access is a major issue. Now, the demand side interventions that have been included in the theory of change include things like distribution of IEC materials, advocacy with community leaders, urban community engagement, strengthening EPI support groups. So these, I assume, are designed to increase the caregivers' motivation to seek care. Right, my question now is, first of all, do you think there is commensurate emphasis on alleviating the access barriers that parents face so that it's more of taking the services to them rather than expecting them to come for the services. And then the second thing is that not suggesting that IEC materials and demand side interventions should not be done. No, that's not what I'm suggesting. But the question is, which will be interesting to find in this study is, can you use demand side interventions to improve motivation enough to overcome such access barriers? So can motivation trump inability? And then one last question for you is, under the process evaluation, would you consider having qualitative interviews with caregivers so that you understand better the pathway to impact, to unpack that impact box from the perspective of the clients? For Dr. Waziri, the question I have for you are, number one, I like the fact that you have included cost data and cost effectiveness data as outcomes for your study. How do you think this evidence can be leveraged to work on some of the entrenched obstacles we know for immunization? There are some things we know that work for immunization. If you do outreaches, you take services to people, you are more likely to increase coverage. However, the reasons those are not happening is that they're not funded, they're not consistently funded. So now you have this cost effectiveness data. How do you think it can be leveraged to promote efforts to secure and sustain funding for traditional health systems investment that have been overlooked? And then finally, can you say a bit more about how you will create different arms in your study? So you're going to compare the cost effectiveness of Z-drop against EV and then against standard care. So given that this is a study that's nested within an existing program and that the Z-drop intervention is really across the immunization systems, you have it in leadership, you have it in service delivery, you have it in data and everything, but the EV is more around going to the communities, door to door, identifying kids and vaccinating them. How would you distinguish the different arms of your study in order for you to evaluate the impact and then the cost effectiveness of the different strategies against standard care? Thank you very much.
Thank you, Dr. Shizoba. And thank you also, Dr. Hamel and Hosini for this wonderful presentation and great discussion that we had so far. I would like, we're going to have a question and answer session, but before we jump into that, I don't know if Dr. Hamel would you like to kind of comment on some of the points made by Shizoba?
Actually,
Dr. Shizoba, may I ask you to also close your microphone? I think that may be the reason. Mine as well. I will close. Go ahead, Hamel.
okay. Can you make it? I didn't understand the question clearly. Can you repeat it one more time?
I didn't ask any question. I was just asking if you wanted to kind of comment on some of the points made by Shizoba on the Bangladesh components. Otherwise, we jump to the question and answer. I'm going to ask also for Nigeria.
It will be better because I missed some question from Dr. Onodi.
Okay. Then, Dr. Hosini, would you like to comment on some of the points that Dr. Shizoba did on the Nigeria components?
Yes, thank you, Gus. Absolutely. For some of the question about how we would like to leverage some of these findings, we're working as a consortium with Africa Health Project Network, that's into immunization, financing, and all that. So they are responsible for the advocacy part of the Learning Hub. So we're going to leverage our working together, the relationship, and then they would be responsible for the advocacy part and would leverage this finding. And because you know that some of these findings are really not, like Dr. Chizoba said, they may not be consistent with what we have already been thinking about, but because of the relationship we have with the Africa Health Budget Network, we are going to have insight into how much is being budgeted, and then how much is how much money is being budgeted for each of these components of immunization. Also, for the question on evaluating the costs for each of the components, yes, because ZDrop is practically going to be implemented in almost every part of the country, while IEV is going to be implemented in some of these our priority local government areas. Yeah, we are going to the study is going to have a non-implementing arm and an implementing arm, so that we can compare these findings between the non-implementing arm and then the implementing part of the local governments. Like the IEV is only going to be from the framework, and IEV is going to be implemented in just the 100 priority local governments. So we are going to we're going to have an intervention and a control group in which we'll study both and then compare findings and then see how both the effectiveness and the efficiency of each of the strategies. Thank you.
Thank you very much, Dr. Oshini. I think with that, we have still like some 12 minutes. I would like to pass for the next stage of the of our webinar on the question and answer from the attendees, and we have collected some questions. Let me go through. I would like first to ask them to Dr. Hamel. I think there are a number of questions for Bangladesh. So I think there is one of the questions that is coming often is about the types of indicators, the process indicators you're going to be using as outputs. I think there is a general interest in taking a look on those. And there is also a question if this is going to be made public at some point in time, because I think other countries could benefit from taking a look on that as well. Dr. Hamel, please.
Yes, Dr. Joshim will going to answer this.
Yeah, thank you, guys. Related to the process indicators, yes. Before answering this question, I would like to add some comments related to Dr. Odino's comments and remarks. Particularly, she mentioned related to demand side interventions and about the issues of scaling up the interventions, whatever are being implemented in Bangladesh. In terms of demand side indicators, I would like to say that suppose the BCC materials, whichever is being implemented in the community for encouraging mothers, for suppose some in rapid assessment report, we found that some of the mothers in remote areas, those who are afraid of related to providing vaccine to their children, because of the children becomes crying after vaccination. So eliminating these sorts of practices, what can be done? So BCC materials and involvement of community, those type of interventions are being implemented. And one issue she has rightly stated that in terms of concern related to scaling up of the interventions after implementation phase, this is a really challenging. But in Bangladesh, the study is being conducted and the interventions are being implemented by the government worker. I see, I mean, that this project is providing the technical assistance. There, all the existing within the existing system, government field staff are being implementing the interventions. So that after evaluation, if the interventions become successful, it would be easier to scaling up. Question Oh, related to process, yeah, related to the process indicators, yeah, this is also interesting things. And for quantifying impact evaluation it is easier to see the changes before and after what happened, changes related to zero dose under-immunized and antigen wise changes what happened before, after, or intervention and comparison. Yeah. And related to process indicator, we will look at do analysis about through observation and key information interview and focus group discussion related to acceptance of the relative changes happen in misconceptions and misunderstanding about the vaccine, acceptability of the vaccine, satisfaction and dissatisfaction about the vaccine as well as the vaccination services. These are the some common indicators that will be focused on for process indicators. Yeah, thank you.
Thank you very much, Dr. Zazin, and also Hamel. I think just to clarify, I think one of the points that you have also in the Bangladesh is that you're going to be using the BAS indicators in your surveys, right?
What indicator? Sorry.
BESD, like the ones that are related to
Yeah,
behavioral
Yes,
social
yes, yes.
drivers to monitor this change in demand.
Yeah, you are, guys, thank you so much. You have rightly stated the various indicators. Those indicators will be assessed, comparison will be done, and assessment will be done both in quantitative and qualitative also. Most of the information will be, the indicators will be covered through qualitative information.
Thank you. And that's something we can discuss about, like making some of these materials public, because I think there may be interest in other countries to do implementation research, and you may be actually generating some kind of a pathway, some pathfinding on like this kind of a approach. So I think that's something we can discuss in the ZDLH project on how to make those publicly available for others. I would like to move now to Nigeria. There are a number of questions as well for Dr. Helshini, and one of them is about what is meant by linking to PHC, what services are offered, how were they identified and prioritized, what effects have you measured to see if these additional services are utilized by children and their families. You want to come in, Dr. Helshini, please?
Yes, sir. Thank you very much, Gus. So for the IEV strategy, I guess he's talking about IEV. Yeah, so the IEV would involve a door-to-door walkthrough in community to identify these unimmunized children, zero-dose children, and missed communities on the settlements, so to speak. So once they are identified, structured questionnaires would be also given, and also geotagging of identified zero dose. Then these children will be given a coupon in which they would use this coupon and they will be linked to a primary health care facility. Where they can access integrated primary health care services in that facility, and then they will be monitored and followed up as they progress.
Thank you. And then there's another question about any kind of early results from the EAV pilot in Nigeria. Do you have anything already? Would like to kind of comment on that after the pilot?
Yes. So what I would like to say is that the pilot was conducted by another arm of Afinet, not the Zero Dose Learning Hub. Yeah, so and even though some of the findings are available, we cannot disseminate the findings at this point in time because it's not been finalized and all that. But once it's been finalized, we'll make it available for the general public to see, and then it would inform also decision making.
Thank you. I think a final question is about the PRISM framework. Why have you selected this framework to be kind of the framework for your implementation research?
Okay, so the PRISM framework refers to a practical, robust implementation and sustainability model framework. It helps in identifying and addressing contextual factors that influence implementation of the outcomes of the Z-drop plan and the INV. So it expands, it's like a form of an expansion of the RE-AIM framework. And then it's a good fit for the RI implementation research analysis because it kind of aligns with key constructs we are studying in this research. Since we'll be considering multiple interventions across multiple levels, a more robust model is required. And then it enables the selection and inclusion of different settings in our research products. And then the key constructs underlying the implementation research are well captured under this model. I think I have tried to answer this question.
Very much. I think we have a couple
Thank
of
you.
minutes more. I will come back to Bangladesh then, because I think there's a question on the e-screening checklist. Dr. Hamel, can you provide, or Dr. Jazin, can you provide a little bit more, kind of in 1 or 2 minutes, what is included in this e-screening checklist?
Yeah, thank you, guys. This is a very important question, and it's a very interesting intervention. Whatever we are observing in field where implementation are being going on, e-screening checklist is a checklist which is used by the service provider. Service provider, I mean not the vaccinators. Other than vaccinators, those who have been providing other than vaccine and working in the fixed health center, suppose the sub-district level health complex, district level health complex, or sub-district level health facilities. Whenever this checklist is very simple and online based, and whenever a mother or a caregiver of a child, for example, visit to a service provider, suppose in a sub-district level health complex for her or his any other problem, suppose maybe suffering from fever. This mother is suffering from fever. So the service provider used to provide services, required services to the mother for her treatment. After completion of this treatment, this checklist is used, and this checklist automatically reminded the service provider to ask the mother or the caregiver whether she or he has any eligible child for vaccination. One question inquired and then if the mother has a childhood vaccination, what is the age of the vaccination? Whether if the child is within the eligible age limit of the child, then the service provider asks whether the child is vaccinated or not, how many vaccine has been done. This type of questioning screening is done and identified the zero dose and under immunized. And after identifying, if a child is identified either zero dose or under immunized or left out or drop out, the service provider insert in with their available tab and send it to. After sending this, the information automatically goes to the concerned health assistant vaccinators, and vaccinator find the reminder and they used to provide vaccine subsequently, and cover is going on. It's a very interesting and very simple checklist which is being staff members of the government of Bangladesh are using very interestingly. Thank you, guys.
Thank you very much. With that, I think we get to the end of our webinar. I would like to thank you all the attendees for joining today and participating in this discussion. We will make the recording and the presentation available. That they will be posted in the ZDLH website and also share via email with all the people who are registered here today. I would like to take this opportunity to ask you all to please register for our next webinar in this series, which will feature the immunization experts from Mali and Uganda, and it's going to be on the 26th of June, now in 2024. As you leave the Zoom, a post-webinar survey will pop up, We would appreciate your feedback, suggestions for topics for future webinars on how to make this better. And you'll also be able to sign up to receive emails updates on new Zero Dose resources and webinar. Thank you all, and see you next time.